Hello, my name is Camella Main and I'm a lead midwife at the London Ambulance Service and consultant midwife at East Midlands Ambulance Service. I chair the National Pre-Hospital Maternity and Newborn Care Group, which is made up of midwives and paramedic leads with an interest in maternity and newborn care from across Scotland, England, Northern Ireland and Wales. So myself and some colleagues across the ambulance trusts have been involved in reviewing and updating the new bleeding and pregnancy guidelines, which sit in the maternity section of JRCALC clinical guidelines. The previous guideline, hemorrhage during pregnancy, has been removed completely, and now this has been replaced with 3 standalone guidelines, which are bleeding up to 20 weeks gestation, bleeding after 20 weeks gestation, and postpartum hemorrhage. So the guidelines were reviewed and updated as part of the 3-yearly cycle of reviewing and updating guidelines, but also they were updated and reviewed due to feedback that we received from staff providing maternity and newborn care within the pre-hospital setting, that they wanted clarity in the management of these situations. I'm going to run through how these guidelines affect clinical practice. We know that these incidents can be really difficult to manage in the pre-hospital setting, and so we wanted to clarify exactly what would be expected in the pre-hospital setting and what could help these women. So I'm going to run through a few headlines. Firstly, in the bleeding and pregnancy up to 20 weeks gestation, we've clarified what is meant by a suspected or confirmed miscarriage. We've also clarified the management if there is excessive bleeding after a confirmed miscarriage. And we've also added risk factors for ectopic pregnancy and some signs and symptoms of ectopic pregnancy, which we've taken from the NICE guidelines. So in the bleeding and pregnancy after 20 weeks guideline, we've really strengthened the wording around this being a time-critical emergency. So any fresh red bleeding, either reported by the woman or seen by a clinician, needs to be treated as a time-critical emergency. And we've emphasised that this needs to be time critical even if the woman's observations are normal. This is because we know that pregnant women can compensate for a long time because of the hemodynamic changes that occur in pregnancy. Also, we've stated that if bleeding stops, it's still time critical because in the pre-hospital setting, we're not able to undertake fetal monitoring. We've also clarified that if the gestation is not known, then if the fundus, the top of the uterus, is below the umbilicus of the woman, it should be treated as under 20 weeks of pregnancy. And finally, the PPH guideline has been clarified to recommend a package of management for all women experiencing primary or secondary PPH. So the management is now standardised, whether the placenta is in or the placenta is out, and whether it's primary or secondary PPH. And this management package should be basically used at any time that there's a blood loss of over 500 mils following birth, or if the woman is showing signs of hypovolemic shock. And it's time critical again, and we shouldn't be reassured by the bleeding stopping. So management includes administering a uterotonic drug according to local guidelines and availability of the drugs, fundal massage and tranexamic acid, and there's an algorithm to show this. And IV fluids should be administered according to the adult guidelines.